Good afternoon. Nice to see everybody. It's 4 o'clock straight up on the mountain time. I am Dr. Randy Fink, and welcome to Fertility with Fink and Friends. Like every Tuesday at 4 o'clock mountain time, 6 o'clock in the east, 3 o'clock in the west. Sure am happy to have you live coast to coast via internet. So we've got a whole bunch of people joining us in here. First, A. Roberson, Nia Amor, and one other joined on that side. So we've got an Instagram feed here. We've got an Instagram feed over here, the CNY, that looks like Fadil Ali. Fadil Ali was the first one to join, so I'm going to send a wave. Hello, welcome. And Tiffany Holiday. Hi, Tiffany is on the Facebook side there, as well as the there's Haley. Hi, good afternoon. We've got Facebook and LinkedIn and YouTube here, and a couple of different Instagrams. So sure is nice to see everybody this week, and happy Tuesday to you. I hope your Mother's Day was very, very special, and I hope you had a chance to see what I did for Mother's Day. I did a little post with a special shout out to my beautiful mother. So I hope she had a chance to see that. Some nice pictures of my kids and of Stephanie. So hope you will have had a chance to take a look at that on my Facebook side. So, gosh, good to see everybody. Wow. A special shout out to Nicole Grossman, who I promised I would say hello to, who told me that who I had a little consultation with earlier today, and she said that she watches the show here. And I think I really appreciate it. Just want to say thanks to everybody. So Mother's Day was a very special day. And I hope for all of you who are moms to be, that it was not something that was a trigger for you, but rather something that was very special, because it is not an if, it's a when. It's when you will become a mother, and there is just nothing like that special love between a parent and child. And so I was hoping that I'd hear from those of you who are trying right now, and maybe tell us what your feelings were about having a Mother's Day. I think Mother's Day is very special, not only for moms and for grandmas, but for everyone who is trying. And I hope that you will accept the hat off and the nod to that. And let me know what your thoughts are. How was Mother's Day for you? When being a mother is something that is still on the horizon. Hopefully something very special. I had an important question here that came by email, and I will start out with that question. And that was, what does metformin do? What does metformin do, and how does metformin help? There are a lot of folks who are on metformin, and a lot of folks who aren't. So the first thing I'll tell you is that metformin is a medication that we use to treat people with diabetes. We also use it in the IVF world, or in the fertility world, for folks with polycystic ovarian syndrome or polycystic ovaries. We can sometimes help to regulate cycles. But in the IVF world, metformin has an effect on egg quality. It also decreases miscarriage rate, risk of miscarriage, and some certain types of pregnancy complications down the road. As it turns out, metformin is really the same medication as the supplement inositol, or myo-inositol. So you may be familiar with that, or you may have been using it, or you may be taking it yourself. If you're on metformin, you don't need to be on inositol, and vice versa. If you're on inositol, you're at the correct dose, you really don't need to be on the metformin. I generally recommend people go with metformin. As you know, I feel very strongly about the list of supplements that comes from the book It Starts with the Egg, and I'm happy to send you that list if you'd like to Instagram me at Randy Fink MD. I'm happy to send you that list. But inositol and metformin really function as the same thing. But when you get the pharmaceutical, when you get the metformin is not an expensive medication. It probably costs, maybe $10 for the month's supply, whereas the supplement is likely to cost you $25 just because it's a supplement, and it may be something that you have to take multiple times a day. So I tend to go with the medication, the pharmaceutical version. It can cause some side effects. The most common side effect it causes is some GI distress, some bloating, some diarrhea, some gassiness, some just general abdominal discomfort. Why does it do that? It's kind of interesting when you think about really what's happening there. So metformin as a medication that treats diabetes drives sugar into the cell. It goes into the cell. And when enough sugar goes into the cells, that can kill off some of the cells. And we normally have cells that are constantly dying and being reborn and growing. And the process of cell death is called apoptosis. And that's a normal part of life. But when those cells that line the GI tract start to die off and slough off, they are probably the most sensitive in our body. That's what causes the GI distress. And so that's why, if you've known anyone who's ever had to undergo chemotherapy, that's why they get nausea and diarrhea, because those cells that line the gut are the first ones to kind of get sloughed off because we just grow some more. That's what metformin does, and that's why it causes those GI symptoms. There are some ways around that. So first of all, I typically use the extended release version of metformin. So it's metformin ER. I usually recommend you take it at night when you go to bed. I usually start with one pill at night for 10 days, and then you increase it to two. And in doing that, you often can avoid some of those GI side effects. Some people have told me that, well, you know what, if you take the two pills and you can't tolerate that, then I would recommend that you split them up. You take one in the morning and one in the evening, and that's kind of the way around that. So metformin does help with egg quality, and so does myo-inositol. They are both really function the same. So as I said, if you're on one, you don't need to be on the other, and hopefully that helps and answers the question. So Haley on the Facebook side said, Mother's Day can be a tough reminder of something that you desperately want to be. And, Haley, I would say, yeah, absolutely. It is something that we desperately want to be, but I would hope that it will serve as a reminder of what is to come, not what might be. And it looks like Katie also, hi Katie, is saying, thanks to CNY, this was my first Mother's Day in 7 years that I actually believe that I'll be a mom soon. First FET is going to be at the end of May. Do an HCG wash. Do HCG wash and intralipids make a big difference for most people? Well, that's it's a good question. The HCG wash, HCG is of course the pregnancy hormone, and what it's doing is that it's upregulating or turning up the volume knob on some of the hormones that are inside the uterus in the endometrium, which just improves the receptivity of the endometrium to your embryo. So yeah, I think an HCG wash is a very good thing. Intralipid as well, it's like an IV version of the keto diet. So it certainly can't hurt. From an evidence base, there's not enough evidence that says that it is something that absolutely benefits everyone, but it does benefit some people, and it's very hard to tell who those people are. So given that it's not overly expensive and that it's a relatively easy thing to do, I do recommend that you do the intralipid infusion. Now, one of the realities of intralipid is that, first of all, it looks like a milkshake, but it doesn't taste like a milkshake. Well, you get it through the vein, so who knows what it actually really tastes like, but that's what I always say. You're getting your milkshake. When you're local to us, it makes it very easy to have that infusion, but in other places, sometimes it's harder to find an infusion center. We recommend that you do it, but if you're not able to do it, it's not a deal breaker. It's not the sort of thing to which you would say, oh, well, geez, you know what, I might as well not even have my transfer. So if you can, yes, please do it. The other types of washes that we can do, in addition to the HCG wash, is a PRP wash. PRP is platelet-rich plasma. And if you've heard me talk about PRP before, I think it's a wonderful thing. We use it in aesthetic medicine. It's used in the face. It's used to kind of regrow hair for people who are losing hair. It can be used in fertility because we can place it directly inside the ovaries, for instance. That's intra-ovarian PRP, which can help with egg quality issues. It can be placed inside the uterine lining to help with the endometrium, and so that's a wash that can be done concomitant with at the same time as your HCG wash. So yeah, I do think it's very useful, particularly in those who have had either multiple failed transfers or in recurrent pregnancy loss. And so that's a great time to think about using PRP. What is PRP? Platelet-rich plasma. Platelet-rich plasma is where we draw a tube of your blood and shake it up such that it separates out your body's healing components or your tissue factors. These normally go into with the red blood cells. And if you've ever seen a tube of blood that's centrifuged, you got a layer of red blood cells, and then you have a layer of the stuff on top, the serum or the plasma. Normally the platelets go to the bottom with the red blood cells, but in PRP, it's a special type of tube so that the platelets and the associated growth factors stay in the clear part, which can then be used for injection. So strongly recommended if you can. Haley is also asking, what are good supplements for an FET? Well, the things that people often forget about with an FET. So basically, and there is a list of supplements that comes from the same book. I'm happy to send that to you, but I will tell you the one most commonly forgotten supplement there is L-arginine. And let me just look over here. I want to see. L-arginine is a supplement that is designed to improve the blood flow to the uterine lining. And so I think it's definitely important. People often take their CoQ10, their prenatal, their fish oil, their vitamin D, very, very important. But the L-arginine is one, please don't forget. Again, I'm happy to send you that list if you'd like. Looking at the Instagram side, hi to Tia Cox. And Nia Amor, nice to see you. Hey, Caitlin. Hi, Grace. Ruzik Blue from Las Vegas. Hello, Las Vegas. It's nice to see you. Hi, Amber. Nice to see everybody. Boy, it looks like, oh, we also have Lena Calvo, another from Las Vegas. Boy, that's a big one. Amber Vince says, thanks to everyone at CNY Colorado for an amazing retrieval experience yesterday. Thank you, Amber, for being here. And thank you for the donuts, because they are always appreciated. That used to be, I guess I can say this because I don't use it anymore, but one of my old passwords for devices was "I love donuts." Krispy Kreme. That is not a particular endorsement of any brand whatsoever, but just reminds me of being a kid. My grandpa would, when I was visiting with them, we'd sleep a little bit late and wake up, and there would always be Krispy Kreme donuts on the table, and just very fond memories. It's amazing how quickly, how fast life goes by, and especially if you are trying to get pregnant, we become so fixated on getting that positive pregnancy test that we kind of sometimes lose sight of the bigger picture. I'd say, the process is a painful one. It's certainly something that we wouldn't wish on people, but gosh, enjoy the people that you meet along the journey. It's really an honor to be able to help every one of you. So thank you, Amber. Hey, Roberson, that's Amber. That's another Amber. I thought I started my cycle last Monday. It ended up being just breakthrough bleeding, waiting for transfer prep, have blood and ultrasound again tomorrow, levels are off. Would you induce a cycle? Can we induce a cycle? Yes, we certainly can. But my guess is that if your hormone levels are already a little high, and you had some breakthrough bleeding, what you're probably going to see is that you're getting close to mid-cycle. So my guess is within a couple of weeks, you'll probably get a cycle of your own. And if that's the case, then you're better off to start your transfer cycle at that point. Myra PJ says it is a blessing, that Mother's Day thing. So very glad to hear that. We've got Ariel with us on the Facebook side. Hi, Ariel. What about baby aspirin and Lovenox? Why take both at the same time in a transfer cycle? And I will tell you also that is not a strongly evidence-based recommendation. But rather it's because they really have different pathways. So at the end of the day, they both sort of function as a blood thinner. Baby aspirin can increase the blood flow really directly to the uterus. And so it can cause an improvement or a thickening in the uterine lining, whereas Lovenox is actually a blood thinner. And it's used to treat many of the small blood vessels going to the uterus, but also there is some cohort of people who have what's called a thrombophilia. A thrombophilia, thrombo means clot, philia means likes to. So they like to clot. These hereditary thrombophilias are typically familial or genetic problems that cause clots in the small blood vessels, and this leads to ongoing pregnancy problems such as recurrent pregnancy loss, placental abruption, sometimes blood pressure complications later in pregnancy, as well as things like DVTs, a blood clot in the legs, or even a blood clot that travels to the lungs, sometimes even stroke. So now certainly the entire population doesn't have a hereditary thrombophilia. Just because you're trying to get pregnant doesn't mean that you've got that problem. But the testing for it is expensive. And we're going to treat you for it anyway. Certainly, I think for folks who have had recurrent pregnancy losses, it makes sense to do that test to see if you have it, because it will have some bearing on things later on in the pregnancy. But usually we use the Lovenox, the blood thinner, in the first trimester, just to make sure that there's no clotting of small blood vessels, and that the baby aspirin, so that the blood keeps flowing to the uterine lining. Now, I will say one other thing about baby aspirin. It is the only proven factor that can potentially guard against hypertensive disorders in pregnancy. So if you, in your last pregnancy, for instance, had the condition known as preeclampsia. Preeclampsia is a disease of pregnancy that is related to the placenta. Once the placenta is delivered, preeclampsia by definition is cured, even though its effects may linger for a little bit depending on how severe it was. But it typically causes hypertension. Blood pressure increases. It can cause fluid retention, which is not a great criteria because everybody in pregnancy has some fluid retention. You can pinch your ankle, poke your ankle, and see, for sure that you're swollen. It can cause an increase in your reflexes, the deep tendon reflexes, and it can cause some effects on your liver and on your kidney and other organs in the body. So preeclampsia is something that we would like to avoid, because if left unchecked, it can result in a seizure in pregnancy, and that is what is called eclampsia. So preeclampsia before that seizure. What we do with that is that we typically induce labor at term, so that it does not have an effect on the placenta, which ultimately it can. As I was saying, the baby aspirin is really the only proven mitigating factor for those types of hypertensive disorders in pregnancy. So if you had one of those with a previous pregnancy, odds are somebody's going to recommend that you be on a baby aspirin in your subsequent pregnancy. So little something to know there. Ruzik Blue says, another year with empty hands, but full of love to give. And those empty hands are hands that are waiting to have something in them. Wouldn't you agree? Let's see. We've got my Instagram side over here. Faithful and Fruitful says, do you recommend ICSI? ICSI is intracytoplasmic sperm injection. And at CNY Fertility, it is the standard of care. We typically perform ICSI for every IVF cycle, unless for some reason you request not to. It used to be thought that, and basically what we're doing there is taking an individual sperm and placing it inside each egg so that we are fertilizing that egg on its own. The reason that we do that, in some places they charge extra for ICSI. That is part of the process here at CNY. There's some people, well, we used to think that, doing ICSI may increase the risk of certain types of birth defects. And now we know that that is not the case. It is not considered to be dangerous in any way. There is no ill effect on the outcome, because what is called conventional IVF. Conventional IVF is where we basically place the sperm in the same dish as the egg and let the sperm swim around and fertilize the egg itself. And there are people who say, well, if that's a part of the natural selection process, that if the sperm itself is able to penetrate that egg and fertilize that egg, it must be a better sperm. Well, we've become so good at looking at sperm and being able to determine which ones are normal and which are not. That really has not proven to be true anymore. And the fact there is that if that sperm cannot fertilize the egg with conventional IVF, then the next day they go back and they find all these sperm in a bunch of unfertilized eggs. Then they have to do what's called rescue ICSI. And that's after the fact. They take one of those sperm, and then they perform the ICSI procedure where you're injecting the sperm into the egg. But by that point, the outcomes are significantly less. So in general, yes, we recommend ICSI for everyone. That's what we do here. Manji 1101 says PCOS and low morphology, IUI or IVF. IUI is, of course, an intrauterine insemination. What I'll tell you is that the success rate of an IUI is so much less than that of IVF. And when you're at a place like CNY, where the cost of IVF is relatively so much less than it is every place else in the country, it almost seems unethical to tell you that IUI is a good idea, because IUI, which is where we take sperm, we prepare them in the lab and separate out kind of the best and the strongest swimmers, and we place them inside the uterus at just the right time in order to try to maximize the opportunity that a sperm will be able to swim along and meet the egg. IUI has anywhere from a 5 to a 9% probability of pregnancy in any given cycle. And one cycle is basically one menstrual cycle, or kind of 1 month, 5 to 9%. Whereas with IVF, we can offer you up to a 60% probability of pregnancy with each embryo you have. And hopefully you have, multiple embryos. So 5 to 9% per cycle, or up to 60% per embryo. IVF is going to be the fastest path to pregnancy, the most reliable path to pregnancy. But it's, of course, the most invasive, and it is the more expensive. So that's a question to think about. But if you ask me, which one is likely to work better, it's always going to be IVF, just based on the technology. Looks like Allie Smith here on the Facebook side. Hi, Allie. Welcome. New to CNY, the consult. You have a consult in August. We started all the supplements listed in the guidelines, as well as keto. So the keto diet is Dr. Kiltz's favorite thing to talk about, even though now he's even more into carnivore over keto. Keto is high fat, moderate protein, and low carb. And I personally think that the most important thing there is low carb. The fat content has something to do with it. He is the better one to talk about that, but low carb is very important because carbs are so pro-inflammatory, and we are all so addicted to carbs. That anything we can do to cut that down, I think, is a plus. Allie, welcome to the CNY family. Ashley just received news that the fresh transfer was unsuccessful and will do an FET next cycle. Well, Ashley, I'm very sorry to hear that. What I do want to tell you is that, we offer fresh transfers because people absolutely do get pregnant from them. To be honest, a frozen embryo transfer is generally going to be of a higher success rate. And why is that? And I'm fond of saying this because it's something I think, we can sort of all relate to. And that's that, fresh vegetables are better than frozen vegetables, right? You go to the grocery store, I prefer stale over fresh. No, we always want fresh. So you would think, well, fresh transfer must be better, right? Well, no, not the case. And the reason for that is that even under the best case scenario, your body has been in egg making mode when you're there doing your retrieval. So even if the numbers all work out good, and sometimes the numbers don't look so good, and we'll tell you, I don't think it's a good idea to do a fresh transfer, and that really does upset some people. But even when the numbers look great, you're always going to have a little higher success rate with a frozen transfer. So Ashley, we're certainly hoping that the next transfer is the one that counts. What else we have going on here? Looks like on the CNY Facebook side, how often should you have your AMH levels checked? And that comes from M. Salustio, who has been with us before, and I think I always have a hard time pronouncing your username there. Welcome. Good to have you here with us. How often should the AMH levels be checked? I like to see where it is, sort of yearly, but sometimes I will have a consultation with someone, and we'll see that they had an AMH from last year. And I don't necessarily need to have it updated because based on where I think it's going and based on where I saw it was, it gives us some guidance into how we think your ovaries are going to respond to medications. So that's really its only use. So if we had that indicator initially, well, over time, yeah, it's going to continue to go down. But if it was 5 years ago, well, I think certainly it's useful. But is it necessary to have it every year? Again, it's a point of data I like to see, but not so much a deal breaker there. Hello, IVF therapist. Glad to have you with us. And Rachel Christina says, this Mother's Day was difficult because it was her first Mother's Day as an angel mom. Whatever your circumstances are that bring you to that position, I think it's important to know that in my opinion, those souls stay with you. They are a part of you and will be a part of you forever. So while we would love to get to hold them in our arms and sing to them and get to know them and watch them grow, that time will come and they stay with you forever. And of this, I am certain. So our thoughts go out to you there, Rachel. And Rachel went kayaking to get away from it all. So, hey, I think that's great. What I saw on the news last night I believe it was in Florida. Maybe it was Florida, or maybe it might have been Hawaii now that I think about it. A guy was kayaking. He was out fishing, and a tiger shark came and took a bite out of his kayak. This was on NBC Nightly News last night. And what did the guy do? He kept fishing. But he got a good GoPro video of that. But he, what an angler. He kept fishing. You got to give that guy credit. M. Wonderland, nice to see you, and welcome Gabby Thorpe and Crystal, and it's just Rhonda. Do I know the cost of a PRP wash? And that comes from Caitlin Dubois. I don't. And I don't really know the cost. And actually, there's a reason for that because what I know is that everything that we do here at CNY, we try to make as cost effective as possible. Certainly, if you're doing intra-ovarian PRP and you do that at the time of an egg retrieval, it costs less than if you're doing it as a freestanding treatment. And you would do that if you're planning to do back-to-back cycles. You're planning to do a stacked cycle, another one, after that retrieval. But if you look in, I'm sure it's on the website, but it's also going to be in your portal in the financial welcome document where all those costs are outlined. There should never be any surprise costs at CNY. But the biggest surprise to me is that I don't know what any of them are. Everything is in black and white, so no surprises. Nia Amor says, Mother's Day this year was extra special because of you and your wonderful staff. You did my transfer last month, and the baby is growing strong. If you're reading this, don't give up. And baby dust to all. God bless you, Nia. Thank you for saying that. Thank you for the shout out. And by the way, did I already say hello to Nicole Grossman? Yes, I did, but I'm saying it again. Are you listening, girl? She wanted to make sure that everybody knew that she is not related to Dr. Grossman in Albany. Okay, now we're all clear. Yeah, that's really a beautiful thing to say. So thank you so much for that. Hi to Jody Hoffman, who is in Hawaii. Jody is our one of our senior nurses here. She has been our nurse manager, one of our OR nurses, and she and her wonderful husband are enjoying a much-deserved vacation in Hawaii. So just please keep away from kayaks and tiger sharks. I think that's probably sound recommendation for everybody. I've got Meg Rogers here on the Facebook side, and Meg says, if a man is fixed, can a woman still get pregnant? Well, so I'm going to guess what that means is that if a man has had a vasectomy, can we still get pregnant? And the answer is yes. So think about what's happening in a vasectomy, where basically the man is getting his tubes tied. And when those tubes are tied, does he stop making sperm? No, there's still a gazillion sperm in the testicles and hanging out down there with no place to go because the exit has been blocked. So typically what we do is that we send you to a male fertility urologist. That's a fertility specialist for men who can very easily retrieve those sperm from the testicle, put them in little vials. Usually you get 4 to 6 little vials of sperm that can stay frozen. But typically that does require IVF. We don't usually recommend an IUI with sperm that was obtained in that manner, just because it's better to have more sperm if you're going to do an IUI. So let's see what else we have here. Myra, who we talked about before, said, I have a blood disorder. It's called von Willebrand's disease. Can this be the cause of 2 failed transfers? My lining is always very thick. I had a laparoscopy recently, and I do have polyps, and my tube was full of fluid. Do you think that was because of the blood disorder? So von Willebrand's disease is a genetic cause of basically a bleeding disorder that may cause you to have heavy bleeding when you have periods. It is sometimes diagnosed in an adolescent who is presenting with very, very heavy menses. It's a simple blood test to find it. But no, that's not so much related to, that has to do with how you bleed if you are, say, cut, for instance, or if blood is coming out of you. You've got a couple of problems there, Myra. So first, you've got polyps inside the uterus. Polyps are a finger-like growth of tissue that sticks up like a tree trunk or hangs down like an icicle. And these can do a couple of things. What they're representing to us is that there's a problem in the uterine lining. So think about it this way. They're hanging out there like this. They can act like a baseball bat and literally bat an embryo right out of the uterus. Well, in theory. But the other thing they're doing is that they're taking up very valuable real estate that embryo wants to use to grow. Additionally, the fact that there's a polyp there is representing something that's gone wrong in the receptors of the uterine lining. So that's something you definitely want to fix. But the second issue you have there, my friend, is that fluid that's in the fallopian tube, which is called a hydrosalpinx. Hydrofluid, salpinx means the tubes. When that inflammatory fluid collects in the fallopian tube, it can wash its way back into the uterine cavity, and that is toxic to an embryo. So I would absolutely, positively recommend you do not consider doing another embryo transfer until those issues are fixed. You do not want to do it with a polyp in place, and that's why we recommend that you evaluate your uterine cavity really once a year, either by a saline sonogram or by a hysteroscopy, and that tubal issue, that tube issue gets addressed. Usually, we want to either remove the tube or put a clamp on the tube so that the fluid can't find its way into the uterine cavity to harm the embryo. So let's see what else we have here. My husband, this comes from Lena Calvo. My husband works outside in the Vegas heat. Should we have his sperm tested for fragmentation? So DNA fragmentation in sperm happens when, so what is a sperm? Sperm is a little package of DNA with a motor on it, right? The DNA can start to lose some of its integrity, and that's what we call DNA fragmentation, literally kind of starting to come apart. And when that happens, typically eggs will not fertilize well. So the number one real treatment for DNA fragmentation is considered to be ICSI, which we talked about before, intracytoplasmic sperm injection. And so we're doing ICSI anyway. The test for DNA fragmentation is also expensive. Is it worth doing? I would tell you, we're going to treat like it's DNA fragmentation anyway. And if in an IVF cycle we see that you have a bunch of good, healthy eggs, but they do not fertilize, that's the indicator that we have a male problem or that we have a problem with sperm, and then it's something we would address. So Vegas heat aside, DNA fragmentation would not be something high on my list. I think that you should routinely get checked. It's usually a secondary kind of measure once we've seen that things aren't working the way they're supposed to. Amara VP says, Mother's Day was very difficult because it falls around the time of my previous miscarriage. Had to sign off social media for the day. And Amara, I get that. The miscarriage thing, may sort of forever be a trigger, but hopefully we can help you here with it being a positive sign for better times ahead. And again, so sorry that you had to go through all that. Okay, what else we have here? What do we have? It's it's 38 minutes after the hour. You're on Fertility with Fink and Friends. I'm Fink, you are Friends. I sure am glad to have all of you here. We'll be here for probably about another 20 minutes or so. And we can hopefully get to all your questions here. I've got one on the Facebook side, comes from Crystal Jean. Hi, Crystal. Storm is knocking out the Wi-Fi here in Georgia. Well, by the way, it is 70 degrees. It was 72 here a few minutes ago in Colorado Springs. So we have a beautiful day here now. Second retrieval is in July, and I am about to start priming. Okay, I thought I was going to prime with Oralissa and some of the medications for chronic endometritis. Today they said it was going to be HGH 3 units a day and low-dose naltrexone. I had 18 eggs and 8 embryos in my first egg retrieval and only 2 5AA embryos. Well, so you're looking at different means of priming. So the priming mechanism that you were doing there using all those different antimicrobials is something that is supported by Dr. Kiltz. The traditional treatment for chronic endometritis or chronic inflammation in the lining of the uterus is with a single medication called doxycycline, which is taken twice a day for 14 days. So it sounds like you were treated for that because you were on Valtrex, Levaquin, Flagyl, and Orilissa is a treatment for endometriosis. Crystal, not knowing exactly what your history is there, certainly if you have endometriosis, using Orilissa and sometimes plus or minus letrozole to decrease your estrogen levels can be a benefit. Sometimes we will sort of throw everything we have to someone to see if, even if we don't know that there's the problem, but if things just haven't worked, sometimes we'll just go ahead and treat you empirically. And that sounds like that may have been what the issue is. But HGH and low-dose naltrexone is kind of more of a standard sort of thing. Now, if you're prepping for an FET, I would want to make sure that you are on the supplements. And that's really probably the most important feature that you can do, again, not knowing any of the rest of your history there. So good luck to you. Rachel Christina says, hi from Cleveland. Hi, Cleveland. Should I prioritize day 5 embryo? Prioritize day 5 embryos and embryo grades of euploids. I think I see what you're asking. So you have done a retrieval, you have gotten eggs and made embryos, and you grew them out to blast. And then you did PGTA testing, and you have some euploid or chromosomally normal embryos. And that's fantastic because those chromosomally normal embryos have our highest chance of success with IVF, and that's about a 60% probability of being able to get pregnant. So, hey, man, that's a great thing, Rachel. So once we know that you have a euploid embryo, the fact that it is chromosomally normal or euploid is more important than anything about an embryo grade. Embryo grading was designed to see, it's basically a beauty contest. It's a number of features that an embryologist can see under the microscope. And each little feature sort of gets assigned some points, and it's through those points that you get an embryo grade. But the whole point of embryo grading was to try to figure out if you could look at an embryo and tell which ones are chromosomally normal. And you can't. And you'll probably know that as well from your own PGT report, that you may have a bunch of different embryos with a bunch of different grades. Some are euploid, some not euploid. You may have euploid embryos that are low graded and euploid and aneuploid embryos that are highly graded. So the grade really doesn't matter anymore once you know that they are euploid or chromosomally normal. Now, should you prioritize a day 5 embryo over, let's say, a day 6 or a day 7 embryo, even if the 6 or 7 are euploid embryos? The answer to that is yes. A day 5 blastocyst, euploid or otherwise, typically will perform better or have a higher pregnancy rate than a day 6 or a day 7 blastocyst. So hope that helps there, Rachel from Cleveland. Let's see what else we have here. Hi, Meg Marnell. Meg is our one of our nurse practitioners in New York. Glad to have you here. If you were interested in those supplements, I see there's some folks asking. I'm happy to send you the list. My username is Randy Fink MD on Instagram. Just message me and I'm happy to send that out to you. Lady Olivia, hello, lady. Would metformin be recommended for someone with implantation issues? So I think the answer to that is yes. Metformin can do things for us, like we talked about in the beginning, can do things for us with egg quality. It can do things for us with implantation and with ongoing pregnancy. So it decreases the miscarriage rate as well. Either inositol, myo-inositol, kind of the same thing, or metformin, I would say yes, is probably a good idea. Um, let's see, hopeful in 2023. I like the name. I recently had my retrieval last week, but was unable to do a fresh transfer due to my progesterone being too high. Will my meds be the same, or should I be doing something different? Okay, you've raised a really interesting point, and this is something that we really see sort of all the time here. And I'm glad you brought it up, because I would like to address that. Progesterone as a level that we check before you do your egg retrieval tells me about the window of implantation. Progesterone controls the window of implantation. And as that progesterone number gets higher and higher, up to and above about a 1.5, that window of implantation gets narrower and narrower until really above a 1.5, the window is probably closed. Now, there are people who tell me, well, but I saw on Facebook that this person had her progesterone was 2.2 and she did it and she got pregnant. Well, could it happen? Sure. There's never any absolutes in this business. However, what it tells me is that it is far less likely to happen than it is more likely to happen. So if we tell you that there's an issue with your estrogen level being too high, although so many of our patients are on letrozole now as part of their protocols, because Dr. Kiltz loves the letrozole, letrozole artificially will lower your estrogen level. So the estrogen level may not be representative. So as a result, that progesterone level may start to go up. And so if the estrogen is too high or if the progesterone is too high, we're going to tell you a fresh transfer is probably not the best idea. And people are upset about it because, well, but the fresh transfer is included in the price. It may mean that I have to pay something extra, and I'm going to do it because we can't afford to come back. We can't take the time to come back. Well, my argument to you there would be, you're spending a lot of money to make these beautiful embryos. And if your progesterone level's high, or your estrogen level's high, kind of what you're doing is that you're putting your beautiful, perfect embryo into a burning building. You're putting into a place that may not be hospitable to a pregnancy. So finances aside, if you're doing something that is just not likely to work on the hope that maybe it'll work, my answer would be hope is not a good strategy in that situation, that you're really better to save that embryo for a situation where we can get you out of egg making mode and get you more ready to be in pregnancy mode. Now, the question was, is it going to be the same medication? Well, you're not going to be doing a stimulation. So you're not going to be getting your Gonal-F or your Follistim. You're not going to be getting your antagonist, your HCG/LH, or your Menopur. It's just going to be strictly either estrogen and progesterone, if it's a medicated cycle, or we let your body do its own thing in a natural cycle. And I am a fan of the natural cycle when it's possible to do that. So different medications for an FET compared to what you had to do for your retrieval. Well, what else we have here? Siciliana Melissa. I like it. Can you have PCOS with only some symptoms and regular monthly periods? The answer is yes. So technically speaking, well, I suppose the answer is technically yes and no. So Siciliana Melissa, you had an elevated AMH, according to what you've said here. When the AMH, or the anti-Mullerian hormone level, is above about a 5, then we know that your ovaries are going to behave like you have polycystic ovarian syndrome, and they may have the characteristic appearance of polycystic ovarian syndrome when we look with the ultrasound. And that is a lot of follicles kind of hanging out. Sometimes they ring around the periphery of the ovary in a sort of ring of pearls type configuration. And in that situation, we say, yep, that's a PCO looking ovary. Now, the fact is that polycystic ovarian syndrome has a very specific definition, and it's involved with chronic anovulation, so chronically not releasing an egg. It's involved with having some metabolic abnormalities, specifically with things like your testosterone levels and sometimes even your insulin levels. So I wouldn't say necessarily PCOS, but Siciliana Melissa, I would say with that elevated AMH, and based on what you're describing, it sounds like your ovaries are going to behave like you've got polycystic ovaries. And that means that we would typically lower our dose of medication to keep you from becoming hyper responsive and then not feeling well. So hopefully that affects, hopefully that is for the positive. Does suppressing with medication for endometriosis help with things? And the answer there is yes. Now, we don't know what cohort of people with endometriosis need to have suppression, because lots of people with endometriosis get pregnant on their own, and we never even knew they had endometriosis. In fact, what's not an uncommon finding in general gynecology is that we go in to do, let's say, a tubal ligation. We go to do permanent sterilization on someone's fallopian tubes because they've had enough childbearing and they're ready to say no more. And we put a camera in or a laparoscopy through the belly button to look around, and they have terrible endometriosis, and they never knew it. They never had a symptom. That's called silent endometriosis. They never had a symptom at all, but yet they got pregnant a bunch of times. Well, if we've tested you and we know that you have endometriosis, or if we know that you have endometriosis and you're having a difficult time getting pregnant, then we often will recommend some suppression with medication before you do your transfer. So as we mentioned, I think last week, with the non-invasive test, which is called Receptiva. Receptiva tests for the presence of a protein that's called BCL6. And BCL6 is something that's in the lining of the uterus, in the endometrium. It's an inflammatory protein that has a high correlation with either fluid in the fallopian tubes, a hydrosalpinx, or endometriosis. So if your BCL6 test is positive, then we know that there is really less than a 12% chance that your embryo transfer is going to be successful. Whereas if we treat that with medication, typically for 60 days with something to suppress the endometriosis, we are altering the way the brain is talking to the uterus. And we can increase the success rate of that embryo transfer by up to 60%. So, yep, in that situation, I do think that suppressing endometriosis is a positive thing. Tori Beth says on the Facebook side, I got my first ultrasound tomorrow and I'm still nervous. Well, yep, absolutely. Is it going to be normal? And yep, that is one of those things that, really, I think most people who have been pregnant can tell you it's not just the first ultrasound, my friend. It's every ultrasound that you're going to have. It's every time you go to the doctor and have a urine test or have your blood pressure checked, or you get an ultrasound to look at things. And that, Tori, is the sign of being a good mom, because you're worried about what's going on the inside. And I think that is it speaks to character for you. And I think everybody could probably tell you, yep, that worry just, sadly doesn't go away. I'd say until they're born, but once they're born, there's a whole other host of worries, right? Is it normal to go in for an ultrasound at 5 weeks? It won't hurt them. Will it? Well, so I will tell you that an ultrasound at 5 weeks is not likely to be able to see the heartbeat. So we usually, can't see the heartbeat until generally after, 6.5 weeks of pregnancy reliably. So before that, what we would see is that we would be able to diagnose and tell for sure that you have an intrauterine pregnancy as opposed to a pregnancy that might be in the fallopian tubes, or what we call an ectopic pregnancy. So the way that works is based on the hormone levels. Once the hormone levels are high enough, we should definitively, with an ultrasound, see that the pregnancy is intrauterine by the presence of what's called a gestational sac, and sometimes even a little yolk sac. The yolk sac looks like a wedding ring if you should happen to see it tomorrow. And those are diagnostic of an intrauterine pregnancy. But it probably will not be till either next week or the week after that you start to see the heartbeat. Really, the earliest chance you could see the heartbeat is typically right at 6 weeks. Sometimes you see it a day or two beforehand. But as the heartbeat first starts to become visible by maybe about 5 weeks and 5 days, it's usually slower than we would expect for it to be moving on. So a low fetal heart rate that is persistent is the sign of an abnormality. So I don't like to check a heartbeat at 5 weeks and 5 days. If we can see it at all, it's probably going to be slow, and that just creates anxiety. And we end up saying, come back in a week, and then we see it at that point, and it has gone into kind of the normal range. So at that 5 week and 5 day thing, it may be the heart rate may be in the 90s or the low 100s. By the time you're at 6.5 to 7 weeks, certainly by 7 weeks, it's in the 120s to 160s, and that's really where we want to see it. So hopefully tomorrow is a wonderful experience, Tori, and congratulations. Hey man, we've got about 4 more minutes here on Fertility with Fink and Friends. So let me see if I can get a couple more questions in. Anna Maria says, at my midway labs after retrieval, where do you want the levels to be? Well, what we really want to see there, we want to see a progesterone level. That's the reason for doing that midway lab. We want to see that progesterone. At CNY, we typically look for it to be above a 20. So progesterone tells us that you've ovulated, or progesterone tells us the level of that hormone that is maintaining the pregnancy. Estrogen builds the lining. Progesterone tells that lining to be ready for pregnancy. So that's the most important reason with the midway lab. IVF for Ali Walsh. Would you recommend HCG wash if I had implantation previously? Well, it's not that an HCG wash is to get you to implant when it wasn't working before. It just improves the odds of implantation with any given embryo. So given the fact that it's not expensive, it's not particularly invasive, it shouldn't be particularly painful. If you can do it, I would say, yeah, let's do it. Let's see if we have one here. This is from my friend Gabby Thorpe. Hi, Gabby. My tubes are blocked and the HSG wouldn't clear the blockage. Could surgery fix this, or do you suggest surgery considered after IVF? I don't recommend surgery in that situation, because can you open the tubes? Yes, you can, theoretically. And I would say sometimes. Gabby, not all the time, but certainly sometimes it'll work. The problem is that is going to be the sign of a damaged tube. And once you have a damaged tube, it significantly increases the probability of an ectopic pregnancy. And the ectopic pregnancy is potentially life-threatening. So obviously that is something we would prefer to avoid. Let's see what we have here. One more question from Erica Plotkin on the Facebook side. When switching from a medicated to a natural cycle, if there is follicular growth, do you continue down the natural path or start medicating again? Well, I think if you're going to use, it's best to start a natural cycle from the get-go, because then we let it go. We like to see it growing on its own, and that means that your own hormones are contributing to the occasion. Sometimes what will happen is that they'll give you some extra estrogen, or they'll give you some estrogen like it's a medicated cycle, but then you have a follicle that grows anyway. And if that was the case, yeah, I would absolutely feel good about switching to a natural cycle where you're going to let that egg get released, get yourself to ovulate by a trigger. And then you only need the vaginal progesterone. You don't need the PIO shots. And that is some of the best news anybody's butt can hear. Fewer progesterone shots. Well, we're going to have to wrap it up for Tuesday afternoon, Fertility with Fink and Friends. Thank you, friends, for the privilege of your time here. Remember that infertility is not your book. It is merely a chapter, and our job here is to help you rewrite that chapter. So until then, and until our paths can cross, God bless you all. Thanks for being with me, and I'll look forward to seeing you next week. Take care.